we have a last presentation left. Our technical team will just...
Till it is start, yes. This is a big disaster, and we all, the person who are working in cath lab, they are familiar with these kind of problems. Probably this presentation is ready, and we are already running.
After this presentation, so we have a last presentation, that is the stent thrombosis and restenosis, and that will be presented by the Dr. Khursheed Hassan.
Thank you. Thank you very much. The exercise complications were all done by the fellows. So this is usually done by the consultants, so the fellows can be happy. So stent failure, mainly thrombosis and instant restenosis. ISR is still important, even with the arrival of drug-eluting stents. 5 to 10% of our PCI volumes usually defined as the restenosis within the stent and within 5 millimeter of the either edges of the stent. Maran classification is the most common to classify this ISR, but bottom line is more diffuse it is, bad it is. And the worst is complete occlusion. So some of the most difficult CTOs are complete occlusion of these stents. Timing usually with the BMS is around 6 months, with DES 1 year, but second generation data, which was released about 2019, I guess, it shows about 2% per year risk, and it is ongoing actually. Okay, it can present as angina, it can present as ACS, and it can be asymptomatic. So why does it occur? A lot of factors, stent factors, extra stent factors, intra-stent factors. Stent factors, most commonly under expansion of the stent, undersizing, stent fracture, gap within the stents if you are placing multiple stents, and then stent type. The first generation stents, which were stainless steel, more bulky stents, as opposed to the present day stents, which are thinner struts and cobalt chromium, the risk of restenosis is much less. So the material does matter. Edge restenosis, which can occur due to geographical miss. If you have missed the atherosclerotic plaque and put a shorter stent, that can happen. Or commonly when you are post-dilating your at the edges, there can be the shoulder of the balloon can't damage the vessel, and that can lead to restenosis. Extra stent factors, if you are putting, if there are multiple stent layers, that increases the chances of ISR. Vessel calcification, because that prevents your stents from being expanded and being opposed well to the wall. Calcific nodules, vessel size. Smaller vessel size, increased risk of ISR, and residual plaque burden. Intra-stent factors, both new intimal hyperplasia and new atherosclerosis, and we'll see a case about that. Okay. So this was about 15, 16 years ago. In the good old times of Cypher and Taxis, so the stents were getting thrombosed several years down the line, actually. So there was an uproar. Why this is happening? So this was the days of Taxis and Cypher, and it was shown multiple studies, both biopsies done by Professor Vinu Brahmani, and that showed that several years after they were implanted, a lot of stent struts were not covered by endothelium, actually. They were nude. And this was related to release of the drugs, which was being released several months after the stent was implanted. So that made the stents nude even several years down the line. And then there was hypersensitivity reaction, more related to the polymer which was used in those early stents, which was causing a hypersensitivity reaction, inflammation, late malappositions, even aneurysm formation with these stents. And that led to very late stent thrombosis after 1 year. One cause of very late stent thrombosis is new atherosclerosis, and that can be exuberant with the drug-eluting stents. Stent malappositions, you put in a stent with STEMI, lot of thrombus, you think that the stent is well apposed, you're afraid to post-dilate very high, and then once that the thrombus is resorbed, there is malapposition. This malapposition can occur with DES, which is late malapposition because of late inflammatory response. So all these factors can lead to very late stent thrombosis, restenosis, sorry. So what do you do? What do you do with when you have ISR? Because there is bulky material inside the stent, you have to make sure that you take care of that bulky material. Because if you want to put another stent there or a DCB, that has to touch the wall. Because if there is bulky material and that is preventing this drug from reaching the vessel wall, the same problem can reoccur. So to get that rid of that bulky material, a lot of things has been tried. High pressure non-compliant balloon inflations, brachytherapy, rotational atherectomies, cutting and scoring balloons, and then two things which have come out are using drug-eluting balloons and using DES for ISR. The data is almost similar, roughly around 15-20% risk of again having restenosis if you use DCB versus DES. And then if it is BMS ISR, then yes, DCB is the treatment of choice. So do's and don'ts, do not rely on angiography, use OCT or IVUS. If you see a cause, don't stop there, look for all the causes why the ISR occurred in the first place. And do not treat without treating the mechanical cause. If the first stent was not well opposed, and if you put another stent, the result is going to be the same. So do consider DCB in preference to DES for BMS ISR, and do use, you can use DES or DCB both for. So this is a case which was done. Post-CABG patient, severe distal LAD, distal left main, ostial LAD, ostial circ disease. Successfully stented, DK crush 5 months back. Now he comes with cardiogenic shock, chest pain, gross ST changes, and this is the result. So what he has is severe in-stent restenosis, distal left main, ostial LAD, ostial circ. So what do you do? So just to stabilize him, IABP, pre-dilatation, and then IVUS, which showed the stents were not very well deployed actually. So NC dilatation, very high pressures, both LAD, circ, left main, and simultaneous kissing inflation with DCB, LAD, coming all the way back into the aorta actually, because it is a small size left main, 3.5 into 20, and he did okay. Okay, this is very late stent restenosis, 2009, good old cipher. So diffuse in-stent restenosis comes with angina. I was done under deployed stent, 3.5 into 38 DES, post-dilated with 3.5 and then 4.0 actually. So stent thrombosis, old problem. Remember 1 day, acute, subacute, and late. Roughly 1% of the cases, but more in ACS, especially STEMIs. High mortality, about 20%, and high risk of repeat stent thrombosis once you have stent thrombosis. Use of multiple stents, smaller diameter vessel, coronary dissection, miss, slow flow, long lesion, and stent malappositions. Patient characteristics, diabetic, low EF, renal failures, and problem with antiplatelets. So this is a OM1 stent for non-STEMI, good result. 3 days later comes with this. So aspiration, gentle POBA, and comes back again 2 days later. Any problem? So there is a stent edge dissection distally, which was not seen in the first touch. Actually, it looks very good. It looked very good. So another stent was placed. So as much as we like to think, whenever the stent thrombosed, it is patient's fault. It is not actually. It is usually a technical fault. So early stent thrombosis occurs within 30 days after stent implantation, when technical and procedural factors are important. A suboptimal procedure result, for example, slow flow, inadequate post-dilatation, inadequate lumen achieved residual dissection and tissue prolapse, is associated with incidence of early stent thrombosis. And stent failure is a real problem, and it is challenging, and it has to be taken care of by a good pre, peri, and post-procedural management. Thank you very much for your attention.
Thank you very much, Dr. Mohammad Khursheed. So we have teas ready, so we'll continue our question and answer in the tea session. So thank you.